At the KSMO studio, time for a sit down with hospital administrator and CEO, Mr. Wayne Reid. Good to see you, my friend.
Good to be here.
And of course, we're talking about Tuesday night's board of directors meeting, which, as we came in, we started talking about that a little bit. One of the interesting things in that meeting, and I'm not going to try to take everything out of order, but we'll kind of touch on it, was distinguishing a name for our hospital, which, as people know, has been called a couple different things over the last 50 years.
Yep.
But we needed to have something definitive and actually register with the state of Missouri.
Yep.
With a name, because one of the things that happened, and I was going to bring this up at the meeting, when I created the name for the radio station years ago, you didn't have to register it.
Yep.
It was just there. Well, then when I got a loan, then they said, well, you're not registered as a partnership. And I said, what do you mean I'm not registered partnership? 1984. I've been paying taxes all this time.
Yep.
Well, there's a form that they did in 1985 that came out, and they made me fill out this form that actually said I was a partnership since 1985. A crazy thing, but I get it. But you do need to have that because a lot of your vendors and things will go back and take a look at those registrations, correct?
Yep. And whenever we file for credit or when we do anything, whenever we do new vendor arrangements, every time we look at that, and when we file for grants and we file for, anytime we file, people want to know what our official legal name is. And I didn't expect there to be a lot of controversy to that, but whenever I came here and went to find what our official legal name was, I couldn't find that, and we talked to Hannah, and Hannah she did a good job of trying to unearth all the documents, and talked to Mark, and he couldn't find it either. So we thought that the best thing to do would be to draw to a place today and make it official so that we could go forward, and it would make it a little cleaner.
Right, because you have a hospital sign that says SMDH, and you have a sign on your hospital that says Salem Memorial Hospital.
That's correct. We have both of them.
May as well be the same thing.
That's right.
There you go. Very good. So it was an interesting. So a resolution actually was signed to that effect. You had one person that disagreed with that change, but it is something that had to be done.
Yeah, I think so.
Yeah, very good. All right. Well, let's talk a little bit about the meeting. You've been a busy guy.
Yep.
I'm just gonna tell you right out now, you've been busy, in case you hadn't noticed.
And so far, I think I've outlasted the British Prime Minister.
She's in a lot of hot water. And doing a better job at
Thank you. Thank you. I sincerely hope so.
Yeah, much better job. But one of the nice things is that we got our CT scanner in, and you say that's going great right now.
It's going extremely well. We've done a lot of patients on that. Bobby and the team are doing wonderful work with that. The nice thing about that machine is not only will it be faster, it's got capacity because as Americans we're getting a little larger, and so it'll help us to be able to do those patients a little better. And the technology of those things are just rapidly changing, and so they were installing some of the 3D software today to make sure that that's available to work, and then in the next couple of weeks they're still trying to get when that'll exactly happen. Bobby's going to go out and have some additional applications training for doing some more of the advanced cardiac procedures on that.
Right. That's something that he would not have had any need to know up until now because it wasn't available.
Some of it was available
with our old CT?
Some of it was available, but in order to do it on this machine, you need to know how this machine works. So and it'll probably be faster and easier for this machine,
Sure.
and it'll produce better results. One of the things that you used to do with a CT scanner is if you had any metal in you at all, you couldn't see it because it would just scatter all over. It was like shining light on a mirror. But this machine is so sophisticated that we can actually look at individual pieces of metal. So if you've got an artificial hip or if you've got a replacement screw, we can see how that's seated in the bone much better, and it doesn't artifact nearly as much.
That's fantastic. And of course, I want to remind everybody that with our radiology department, you can have a cash option too.
Yep.
You do not have to always go through an insurance company. If you do, you can always go through central scheduling and get that done as well, and they can do a lot of that footwork for you if you need to get that done. But if you want to pay for it yourself, if you want to get a CAT scan, MRI, whatever, you can.
Yep.
And you can
still have to have a doctor's order.
Just have to have a doctor's order.
Yep.
But you can call and see what it's going to cost, and you can work that out, and you can pay for it yourself.
There you go.
So that's always a good
And
thing.
actually, some of the things that we're going to do in the future that I think are very good, lung screening is not often paid for by insurance, and
Not very often.
and then cardiac screening is not paid for by folks. So we'll have a cash option for those because I think those are valuable for individuals, and we'll have a cash option for those things.
You got a few of those when you had COVID. They would pay for, I think, one.
Yeah.
One?
Yep.
I mean, if they find it, then how do you know you got rid of it if you don't take
There
the
you go.
second one? Somebody's going to pay for it, and you're going to pay for it. But nonetheless, but very good. I'm glad to see that everything's moving forward, and that should be in full swing here with Bobby coming back from his training. And
In the
you know,
next
I'm
month or
saying
so.
by November,
Yep.
1, you should be ready.
Longabouts
ready
there.
to go.
Yep.
Oh, very good. So very good. All right, so you had a nice meeting in October with our friends at Doe Run and their
Yeah.
Human Resources Department, trying to get that all resituated.
Yeah, and I will tell you that the nice thing about that is that we actually got to tour the mine and got to meet some of the people that work there, and that is a wonderful community there. We got to meet some of the folks in Viburnum, got to see the mine, got to talk to some of the people who are actually there, and they have you can tell that's a very good culture there. And so we met with them, and one of the things that has happened in the intervening period between the time that we were really their prime provider and now is that they've determined that some of their needs have changed. So they're going to go through and try to figure out what their actual needs are, and then we'll develop some bids for them and
good.
see how we can connect to them and make that work.
They've been linked with the hospital for many years, and nothing should change there. But you definitely want to make sure that you're addressing what they need.
Yep.
And you have a lot more to offer now.
Much
with
more.
With the new CT, obviously, but our MRI with the
Well,
open bore and things of that nature, the stuff they didn't have before.
Yep, and I will tell you that I was talking to Joe and Jim yesterday in our lab. We're blessed here. Some of the newest lab equipment I've ever seen. I've been in much larger hospitals that had less effective and less modern equipment than we have here. So we're blessed in this market to have in a hospital that size and in this location to have some of the equipment that we have. It's very state of the art.
And while it is October, we want to remind everybody it is Breast Cancer Awareness Month. Do schedule that mammography.
That's great.
And mammogram through the mammography unit. It is a fantastic unit. It's 3D. It's state of the art. Ladies, if you haven't done so yet, please call radiology and get that scheduled.
And our ladies who do that are extremely dedicated to that cause. So they look forward to doing that. This is their time of the year to shine.
Yeah, it didn't get brought up in the meeting, but I wanted to make sure we touched on it here.
Yep.
And because it is very important, and so please get that done. 729-6626. Just ask for radiology, and they'll get you to the right people, and then you can schedule that and get that done. Breast cancer awareness. We
And
really
Bobby
want
was
to get
telling
that.
me that we may hit a record this year for the number of mammograms that we do.
I hope so.
So
I hope
that
so.
would be great.
It's a much needed service to our community, and boy, I tell you, the donation that was made, it's fantastic. It's just
amazing.
a fantastic machine. Beautiful. All right, one of the things that you did discuss was we have had a few problems with our phones and the collection of faxes in the queue.
Yeah, so when I got here, we had a I would say a pretty good stockpile of faxes. My sense is that a lot of those were duplicates because people got frustrated and faxed it back.
Faxed again.
And then we were having difficulties getting our phone answered, so we put some operators in the building, and I would say that we went from having lots of faxes in our fax queue to this morning I think we had 13 in our fax queue, which is a normal amount that you would just
Sure.
that you're sort of like you got 13 sitting on your fax machine
Right,
and you're going to get to those. So that's good. And then our phone system, we were struggling with getting phones answered, and I think for the board I reported that on the Monday before the board meeting we had 250 calls come in and we had 242
46, I thought.
yeah, 242, something like
Yeah.
that answered, and 4 of them went to voicemail. Or one of them went to voicemail, and a few hung up.
Say
So,
one home, yeah.
yeah, so so that's what I would call a normal traffic pattern. We did that with just 2 operators, so they're doing a great job, and I would say that we will continue to follow that and to make sure that it doesn't become a problem again. But I would say that as of today, those folks have done great work, and that's not an issue at our clinic anymore.
when we met last month, we talked a little bit about the work of putting some new registration windows out at the clinic, and that has been done. Now we're working out all the bugs, right?
Yep. I've done a lot of construction in my life, and every time you do construction, you get the blueprints and everything looks good. And then when you step into it in person, you go, oh, we should have done this. And this is one of those things. We got the new windows in; they look beautiful. Contractors did a great job. It looks wonderful. The one thing is that we had decided to use desks behind there, and that's probably not going to work. We're probably going to use some counters, and so we're going to have them come back out and put some counters in. But otherwise, they're in function. We're using them. They're just not ideal yet.
Closing in on it. We're getting close.
Getting closer.
Getting close. Dr. Munfalk, saw his first patient.
Yeah, he's one of our new cardiovascular surgeons that's coming in from up north, and he's met with him for the first time. He's a true professional, and so he came down and saw 4 patients here. He didn't want to see a whole spate of folks, because anytime you come to a new organization, you're learning us, they're learning you.
Exactly.
And so he wanted to do. He saw 4 patients, and next month he'll see 20 patients. So that's good to be able to offer that level of service in our community.
And that's fantastic. And this man's top. I mean, he's one of the best.
He is spectacular.
He's fantastic. So that's fantastic. And we got a new ER physician.
Yes, our new ER physician came in on a week ago, and he's actually done his second. He's actually done his second rotation through our clinic. He's helping us on the weekends, and had great things to say about our ER. He's engaged and is having a great time.
It's good. That's always good. And he's excited.
He is.
Man, he's excited. He's excited about being here.
He's full of energy. We saw him over at Main Street Cafe. I was eating breakfast. He came over, and he likes us. He likes us. It's a good fit.
That's very good. Very good. 340B audit.
So we had a 340B audit, and I don't know if you know what the 340B program is.
Pharmacy program.
Yep, it's a pharmacy program, and what it does is it allows for patients who qualify to pay a reduced rate for
much reduced rate
for medications. Yeah. And the neat thing about that is that, unlike a lot of programs, that's not funded by the taxpayers; it's funded by the pharma industry. Right. So they are required to offer those drugs at a reduced price. And what we have to do is we have to make sure that, because we're offering those at a reduced price, that we give them to the right people and that the people qualified for them. We had an audit that came through, and the only issue is we had a couple of patients who were on our inpatient side who got 340B pricing for a couple of the drugs, and we're trying to figure out if that was because they started out as an outpatient. But otherwise, we did, it was a good survey.
Yeah, so one minor little thing like that can be corrected. Just had to find out where it came from.
And that's why we look.
Yeah, absolutely.
That's why we do the audits, to find those things.
And then Chrissy Decker is getting on board with the the clinic director, and she said you said mid-month, but we're already mid-month.
Yeah. So the reason, and the only reason that we haven't done that is because we're waiting on the stuff to come back from the government, and sometimes that takes a minute. They're still, I think, probably recovering from the infrastructure shocks that came from COVID, so they're a little behind. But as soon as everything clears and we're legally able, she'll be there. I do want to shout out to the clinic who have done a great job in the last 6 weeks. Tina's helped. All the providers there have pitched in, and I think it's moving in the right direction. And so we'll be glad to have Chrissy join that team and help them.
Right. And Dr. Neely's been going now for a little over a month, and we have a new nurse practitioner coming on board, right?
Amber's coming on, and we have a couple more that will be there. And then we're hopefully towards the end of the year, when we get our new clinic manager, we'll talk about how to do this. We'll start offering some weekend time so that you don't have to wait on us, and we'll have a walk-in clinic and then some weekend scheduling too.
Fantastic.
So that should come up soon.
Always nice. Christy Gorman, your home health director, came in and gave her report. They do it every 6 months, correct? Mm-hmm. And really updated the board on the different patient survey results and admissions and why they're there, the infection results that are there. And it goes through a lot of different things, new requirements from Medicare, as there always is. Mm-hmm. And it's hard to stay on top of that, but Christy has a good, I guess, leader there, because Ashley Sullins did this job, and she can help tweak anything that Christy is still learning.
Yep. So she did a good job presenting that information. I think the big thing that will come is that we have been in the regular acute care setting for a long time, we've had our payments tied to our HCAP setting to make sure that our patients are satisfied with our service, and now that is moving into the realm of home health, and so we have a 4-star rating right now, and so that will mean that we will have all of the reimbursement fully available to us because we have that rating. So they do a good job there.
Now, Wayne, I think it was last year that Ashley brought up at the meeting that they changed that payment. They used to get a 60-day payment ahead of time, and then you get reimbursed, and they stopped doing that as of, I think, last January 1st of this past year, correct?
Yeah.
So that makes it a little harder on home health because you don't have any dollars to spend. You have to put it all on your bill, right?
That's correct. That's correct. But I will say that home health is a service that we like. It's and I've actually talked to Christy about how we could expand that a little bit so that we can reach out. And I know that she's doing yeoman work. When I know that just not very long ago we had, we had probably 10 or less patients on our books, and now we consistently have 20 patients. Right. So that means that we're doing the right thing and reaching out and helping the people in the community that need it.
I always like to look at charts, and when I saw the overall rating we had was 81%, but we had 83% said they recommend us.
That's very, yeah. So and I've always that's an anomaly in almost every statistic like that, and I think that part of it goes to I don't want to come there. But if I have to come there, that's where I'm going to come.
That's where I want to go. Yeah.
That's where I want to go. I don't want to have to come back. So I think that's what that is.
And I like the pie chart on the admission by referral to see our local doctors are working with it. But there might be other institutions that are helping with the home health as well, right?
So people get their health care in a variety of locations. Obviously, we'd like for that all to occur with us, but we know that's not what happens. But what we want is every time that we can get them closer to home, we want to be able to take care of them closer to home. So as they get back in and need home health, I'm glad that they're choosing us.
Yeah, I like that 4-star rating, and I remember before when we would look at that, and you'd see other home health agencies around us, some as low as 2.5.
Yeah.
And you're wondering why, when you have this one here at 4, why would somebody want to use that other one? Why? But it happens.
It happens.
I understand.
And I will say that one of the things that we want to do is we want to be collaborative with our our colleagues in the area, because we can't provide all the care, and they're going to be there, so we want them to be effective too. So.
But if you had your choice,
they should come to us.
Yeah. If you had your choice, why wouldn't you go to a 4-star?
That's where I would go.
And probably going to get a little bit better care because it's going to be a little smaller, going to be a little bit more intimate, and we all know that helps healing. It just helps healing. When you feel better about yourself and more comfortable, you're going to heal.
So I tell people that all the time that there are certain things that big city medicine is good for, and you need that. We need big city medicine, but there are certain things that I wouldn't prefer. If I've got a pneumonia and I just need to be in the hospital for a couple of days, or I'm dehydrated and I need to be in the hospital for a couple of days, I'd much rather be in a place that's small. Right. And close to home, so that my family can visit me, and that I know all the people around me, as opposed to a big busy place where I'm the least of their concerns. Every patient that comes into a hospital like ours is the height of our concern.
Sure. Well, when you get into the bigger hospitals, I know my dad was in and out of the hospital here 3 years ago before he passed. You're a number. Yep. And they moved him around. He was in for 10 days. They moved him 9 times. And every time I go in there to see him, I go, oh, he's no longer in this wing. He's over there. And I didn't authorize this.
And you didn't know where they were?
No.
You didn't know where to park?
No.
So now you've parked in one place. You've gone into the building in this area. You go where you think he is. He's now moved over there. You make your way through the maze of the hospital to the new place he is. Now you can't figure out for the life of you how to get back to your car. And all of those things add to a level of aggravation that makes it more difficult for you to be the caregiver that you need to be in those times.
And frustration, because you may have a limited amount of time you're there, and all of a sudden, I don't know where he is.
And it's eaten up walking all over a big hospital.
No, my dad was 94, and they put him in pediatrics. Why? And I said, why would he be in pediatrics? Well, there was a bed available there, and we needed the other bed for somebody. Why? I mean, that doesn't even make any sense to me. Yep. So we won't even go there. But,
But that's why we have local hospitals.
And that's why I made my I made myself clear, I think, to their administrator. That's uncalled for.
Yeah.
Because my dad was confused every time he woke up. He was in a different place.
No idea where he was.
No. And at 94, he was getting scared that he's losing his mind. He goes,
Yeah.
I wake up, the wallpaper's different, or this is different.
Yep.
I go, yeah. Well, Dad, you're in a different room. He goes, I didn't authorize this. I said, neither did I, Dad. Neither did I. All right, so let's take a look at the summary of operations. A little bit below budget on most numbers, but still a fairly solid month.
Yeah,
for
we
the
had a
hospital.
solid month, and I'll say part of the reason. So we're still trying to figure out what our
I want you to explain this, why they're below budget.
Yeah, so there's a few things that I'm not entirely sure of after 6 weeks, and some of it is we're comparing ourselves to last year. We had a COVID year last year, so there's a huge difference in the way that was. And then the other thing is that because we had RHG come in and we had some new players in our finance team, and so they had to do the budget quickly. And normally what you do with the budget is you'd say, what do we normally do in September, and what do we normally do in October? What do we normally do in August? You would base your budget based on season and month. Well, last year they didn't have time to do that, so they just took, well, this is the number for the year, and they spread it out over. So we had some. So I think, and I haven't confirmed this, but I think that part of the reason is that we had a big pickup in August and September last year of COVID patients.
Right.
So we're comparing us to that anomaly, and then we also budgeted a higher volume than we probably would normally see this time of year at the end of summer, when we normally see a lot of patients in the fall and winter.
Right.
I think some of that's there. Not making excuses, but I think that some of those are anomalies in the accounting. But we still watch it very closely.
So, being that I graduated with an accounting degree, I like to look at numbers. And one of the things that when I remember talking to the finance committee, I said, you guys, even the year before, you guys have a major problem here, because when COVID hit, the hospital basically only accepted certain patients.
Yep.
So no surgeries.
No outpatient.
None of this.
No
outpatient
physician
surgery,
office.
Nothing. So how do you make a budget? And so we're trying to go back to the previous years. Well, if you use the past 3 years or 5 years, well, Wayne, just like you're saying, last year was skewed high. The year before was skewed low.
Yep.
Now all of a sudden, and then you didn't even offer some of these services you are now in those prior years. How do you budget that? And like you're saying, you may budget on the high side because you think we've got these more services. I'm sure we're going to use them. Well, how could you even figure that with COVID in 2020 and 2021? You had another outbreak in the late summer.
So
how do you figure that?
And then in the midst of all that, we had sort of a little financial crisis at the end of that we were trying to dig out of.
Just a rumor.
Yes, and so it does make it difficult to compare. And so what I use, and then the other thing that I will say that is probably on the next slide is our outpatient stuff, is our ancillary procedures, and those right now are all sitting in one bucket. And so our ancillary lab, X-ray, pulmonology, all those people do both inpatient and outpatient.
Right.
Well, those should be in separate buckets, and we need to look at what those are, because those have different impacts on the staffing, those have different impacts on the department, those have different impacts on the community, and they certainly have different impacts on their finances.
Yeah.
So we need to be able to know what's happening on our inpatient ancillary services. We need to know what's happening on the outpatient ancillary services, so that it's all so that we're paying attention, and it's right.
I asked a similar question when they opened the lab up in the clinic.
Mm-hmm.
And I said, okay, so I'm getting my labs done here. How's that going? Oh, it's all still being done at the hospital, but you're taking my blood here.
Mm-hmm. So that's
how many people was that being done there at the clinic? How many people actually walked down to the hospital and got it done there? I said, how's that being separated? They didn't know.
So right now, it is not being separated out as we count it. It is flowing into one pool in the hospital side, which is not uncommon, because in order for you to draw it in the outpatient in the clinic setting, if we did it there, we'd have to have a whole separate lab, which is
right.
Very expensive and hard to operate. So we do that, and that will get into our outpatient numbers. So at some point, we would like to know where our volume is flowing from. So we'd like to know how much of that is clinic-based and how much of it is regular outpatient-based, and how much of that is inpatient-based. Right now, I'd be happy with, for the first little bit, to make sure that we know what is truly what's outpatient versus
Right.
inpatient.
Right. And it just makes sense.
And I will say also one of the things that we're doing is we're trying to look at from a provider level which providers are using our services, which providers have a high lab utilization, which ones are using our ancillary services, so that we can track it that way.
And really, and that's vital.
We
Because
need to know.
You need to know. You definitely need to know.
And one of we had our first town hall meeting this morning with our staff, and I was explaining to them that that it is our job to manage the finances of the hospital. It's their job to make sure that we do good care, and so and this is one of the ways that we do this is we want to make sure that we understand where all our volume is coming from, how does it impact, and are we matching our expenses to our current volume. If you don't do those things, it's a little more complicated, but it's not all that much different than running your home expenses.
But you can isolate things by separating that out. You
Yep.
can't isolate it right now because you don't know where it's coming from.
Yep, and some of it is in the way that we have used some of the systems we have. I think our new computer system that we just went to in the lab, in the clinic, will allow for that in ways that are automated. Unfortunately, some of what we're doing isn't making as good a use of that as we can, so we're going to work on ways to make that a little easier so that we get automated reports. I'm accustomed to walking in and seeing a dashboard every day that tells me what the health of my hospital is, and
Right. Like a spreadsheet all the way across.
I just see it on a screen. I can see it on a screen and just sort of know what's happening in my hospital. We don't have that here. We have all the data, but it's not put together that way, and we're going to work on a way to do that so we can see what the health of the organization is, very much like a patient.
So yeah, right, and so the clinic did switch over to CPSI before you got
Just
here.
before I got here.
Yeah, and so that conversion that's pretty well all complete.
Yeah, I
now,
think it's
right?
pretty.
I mean, we
well,
still got to do some. I know we're going to
Yeah,
talk about
yeah,
that in a minute.
yeah, we
but,
still got some
But as
things.
far as that introduction to that, and everybody's getting a little more comfortable.
Yeah,
with it,
and I would
right?
say that, it takes months to a year before people are fully converted in a new software program. It is because it drives what they do. So I would say that they're doing yeoman work and have done good work for the first 2 months, and so that is settling down some. But there will be hiccups for the next few months
sure.
because it's very, very, very complex.
The old learning curve doesn't change. It doesn't matter what it is.
Well, mine changes. I think mine is shallowing up a bit.
Yeah. Takes longer for that to come back
That's
up.
what I'm saying. It shallows. My
Stays
learning
down
curve
low for a long time.
Mine's shallowing up a bit.
One of the nice things that and I was glad to see is our long-term care is full again.
It is full again, and I think I shared the last time I was here that I was over there just day before. What is today? Today's Thursday. They run together. I was there Tuesday and was walking through the clinic, walking through the long-term care center, meeting folks, and that's sort of therapeutic for me. Get to meet some of those fine folks over there that are residents, and we're taking good care of them.
You learn a lot from those people.
They're phenomenal people. So I told folks if you can't find me, I'm either outside taking a walk around the building, or I'm over getting a little long-term care facility therapy.
September, a busy month for the ambulance, 225,
Very good
166 patients. And dry runs have always been about 35 to 40%. And it doesn't matter what month. It's going to be pretty consistent. If you get down to 30, you're feeling pretty good.
Yeah.
But they have to go on when they're called. And I also want to thank the hospital for all the great work that they do with the sporting events, because there's always an ambulance at those football games. We had the rodeo on Labor Day back, and of course there's an ambulance there. So there's a lot of services, Wayne, that I don't think people really take notice of until it's not there.
And I will tell you that one of the things that's nice about having the ambulance service attached to the hospital is that it is not uncommon for an ambulance service in the hospital to be a little adversarial. And the fact that this hospital has its, manages the ambulance service allows for that to be much more collaborative. So that's good. The other thing that's interesting is that if you go to the trunk or treat on Halloween, you might see one of our ambulances there.
There you go. The new one? Or
One of the new ones, yeah.
Wow. Great. Really like that. So emergency department, busy. One of the things that you do look at, that the board actually gets a chance to look at, is the people who were transferred. You got to
Yeah.
go through that transfer list, and there are some concerns that some people may have been transferred that it just didn't need to be.
Didn't need to be. So we're working through what those, and again, you know, you don't want to second guess your providers, but you want to make sure that they are aware of all the things that we can do here, and so that if we have patients who could have stayed here, we want them to stay here, because just like we talked about before, if we're appropriate for your care, this is the best place for you to get it.
Right, and you have a new emergency room physician on staff now, and if he's not familiar with what is there, he
That's
needs to
correct.
be made aware.
Yep, and so we want to make, so we're, and I think last month was probably the first month that you saw that all of the reasons, not by patient name, but all the reasons for the transfers out were there, and we're going to try. And I had some conversations a week or so ago with BJC and their transfer center about where those patients were going, and how do we figure out who's going there, because we, again, you know, they're busy. And, you know, if there's a patient we take care of here, we don't need to stress their system, and we
Sure.
need to use ours appropriately.
But we actually had a birth.
And we did.
Right here.
We had a birth. That's not what we normally do, but we're glad to be available.
Well, it's good that we have a hospital that close when that service is needed, that they were there.
Because, you know, we've tried to talk to these babies, and sometimes they just don't listen. When they're ready, they're sometimes ready.
You know, not yet.
No,
Not yet.
sometimes we don't get to pick. Sometimes
No.
they pick for us.
Mother Nature has her own way of making that happen. So, but I think it's a great slide to actually let the board know these are why people are being transferred, and it's not just you just don't want to transfer somebody because, hey, I don't want to be here. If you need medical care, you need to be here.
And I will say that one of the things that's nice about having this is, even if you do need care outside this area,
Sure.
we can get you stable here.
Right.
And the long trip between here and someplace that you need goes much better if you start out here, and we can get you stable, and we can get you started on the treatment that you're going to need when you get to the new place.
Exactly.
So this is minutes matter in healthcare.
Absolutely.
You
And
wanna-
then, being in the level 4 STEMI and stroke center that we are, that proves it, because got to have that time.
Yeah, and I don't know. I've had so many meetings in the last few days. I don't know if it was mentioned here, but I think last month we had our STEMI survey, and they were very
Right,
complimentary,
right, yeah.
very complimentary of the level of care that we give in our STEMI center.
Yeah, I remember when Tabitha Stanfast brought all that to the board a long time ago, and wanted to do this, and boy, the board got on board with it, but didn't know. I don't think they knew all the steps that had to be taken by Tabitha, and she did a tremendous job getting that implemented.
Yep.
And it's just gotten better and better and
Yep.
better. And really, it's a fantastic job, and it's good to see that she's still here.
Yep.
You gotta like those people that they've got that experience, and then they keep on top of it. It's just a great asset to the hospital. All right, so and when I look at we get into the financials. Obviously, the balance sheet very, very, very stable.
Yep.
And the liabilities expected, nothing out of the ordinary there that I saw. So I'm looking at it good. Yeah, we do have a little long-term debt now, but that's to be expected.
Well, and if you look at our debt to income ratio, it's very solid.
No, it's good.
It's very solid. I've been in hospitals that had a much higher debt to income ratio than this one. So the fact that we're doing the things that we're doing with the little debt that we have, that's in fact, I would say that made this recovery a lot easier. So that's very good for this hospital.
And I like the term you use, little debt, because most hospitals have some debt because they have either lease purchase agreements, or if they have to buy equipment, it's on a long-term basis. It's going to be there. But for years, our Salem Hospital had almost no debt at all. And I said, you guys, you need to improve these things and get up to date.
And you have to use debt judiciously. You can't. It's not what it's sort of like you don't want to have to mortgage your house to take a vacation, because that's maybe not the most.
That might not be a good idea. When you get back, that house may not be there.
Yeah. But you want to be rational in it. But taking a debt to buy a house is not a bad thing.
No.
So, you just have to make sure that it's in your budget. And if we ever decide to build a new hospital, I suspect that we won't be able to come up with $30 or $50 million of cash. And I'm open to that if somebody wants to donate it, but we will probably have to carry that as a debt, to be able to finance a new hospital.
And what people don't understand about debt, Wayne, I think, and this is one of the things, is you're actually taking future dollars and matching them up against the future value of the hospital. Yep. And I remember when I was learning accounting and we started talking about this, and that's why you go in debt. How much is this worth to you? How much can you pay now? And then how much over time is it worth for you to be able to match dollars versus expenses?
And how much
and make a profit
and how much going. And how much better is it to buy at the current rate of dollars today versus how much those dollars will be worth in 5 or 10 years when that loan finishes.
Right.
If you can buy if you've got good value in your dollar today may be the best time to buy it, and then it essentially locks in that value
right.
today.
And instead of paying full cash for something today, even with today's dollars, $2 or $3 or $4 million, if it's going to kill your cash flow, you can't do it.
You need to preserve your cash.
Yep.
You need to preserve your cash.
You still have a hospital to run. You can't just go buy a brand new 2 ambulances out of nowhere if you don't have the cash. You can finance them or do a lease purchase. There's all kinds of ways of being able to get things done.
Yeah.
But you have to explore them.
And there's bonds that you can avail yourself
Sure.
of. There are ways to do that are appropriate, but you have to be judicious, and you have to do them for things that are going to advance the cause of the hospital.
BJK, when they do the auditing and they come back, and I know we're going to get a report here very soon, I always look at the ratios. I guess that's the accounting in me, but I always look at the ratios. And sometimes I remember our debt to equity ratio, it was like 12 to 1. I thought, well, okay, that's fine. That's great. It's fantastic. However, are you making improvements to the hospital to where that could be a little smaller, but now you're upgrading everything?
Yep.
And as we're talking right now, transformer went down, that you've got things in a 50-year-old hospital that probably 20 years ago, Wayne, should have been looked at being replaced.
So it's funny because, and I know this will come up in a minute, but I think I've had, I don't know how many things that have just sprung up suddenly over 20 years ago. In this hospital that we've known about, the phone system, the thing under the floor. I mean, the transformers, all of those things, and it's a little different in a public hospital, non-for-profit versus a for-profit hospital. We have to be solvent,
sure,
but we're not trying to impress investors with our stock value.
Right. Yeah.
We need to be appropriate and provide services to the community and do it in a way that we can know that we're going to be able to provide those services 10 years from now, not just 10 days from now.
Yeah, strategic planning starts with looking into the future and what you're going to need. A 50-year-old hospital, now you have to look into the past to see what you're going to look at for today.
Yeah.
And so once you get that all caught up, though, it'll be great. But there's that time frame of getting caught up.
And as we were talking before we started here, in a 50-year-old building, it will always be something. It will always be something. And I think I showed in the meeting that night that some of the things that make this difficult is you can fix 50 years of issues. You can replace a 50-year-old transformer.
Sure.
You can replace a 50-year-old regulator valve, but what you can't do is it's really expensive and difficult to fix 50 years of of inappropriate infrastructure.
Yeah. Bad design.
Bad design is hard, and I didn't want to be critical, but bad design. Our hospital's at the bottom of a hill. We've got our incoming water next to our electrical. So those are things that are things that we need to be cognizant of that are really difficult to fix that's not a repair. That's a harder thing to fix.
And I think as I look at it, of course, I'm from St. Louis originally, so I had to deal with unions and things of that nature and all kinds of requirements by municipalities and not only the state but the county of St. Louis. Well, first off, putting those two, just like what you're talking about, never would have ever been done in a building, but out here they didn't have those codes.
Yeah.
So it's a building, it's a maintenance building. We're going to put everything in that maintenance building, and I mean everything.
Everything went in there.
And
everything
so it did. And as you're seeing right now, it's a little cramped.
So well, it's not just cramped. It's
Well, I meant cramped with too much stuff in there.
It's curiously compiled.
Yeah,
I'll say that.
Yeah, that might be a better term.
You know, in my 6 weeks, I've had the opportunity to be up on the roof of the building.
Oh boy,
I've been, you know, and I've looked at how we've maintained that. And I will also say, however, for a flat roof that's been maintained as long as it has, it's been well maintained. So I feel good about that. Our maintenance team really does do a good job with what they have. So I've been there. You know, I was when we went through the power outage on Tuesday when we did that transformer. It was not the first time, but I've been in our powerhouse before, and to be in the mechanical room and to see that. So the current staff is making the best of the situation they have. And at some point, I'd like to be able to give them something that's a little easier to maintain.
Yeah, it would be nice. But while we're actually talking about the maintenance and Todd Workman and his staff down there doing this, they had a lot of work to do in helping out and getting this transformer change over and getting things ready to go and relief valves and all this stuff.
Yep.
These guys are on top of this. And tell us how important that really is, because without their knowledge, of course, they're working with the electricians and things of that nature in County to make this all happen. But without their assistance in this, you wouldn't have anybody at the hospital who knew what to do.
And it was as simple as we showed you in the picture. You saw in the picture.
That's what our listeners can't see.
Yeah, I'm sorry. I'm talking, but there's cables. There were 32 cables that are the diameter of a quarter. They're just huge. They're huge cables.
They don't bend well.
They don't bend well. They don't move well. And so the original intercounty request was that we not pull those into that room until we had powered off the building. Well, if we'd done that, we'd still be off power from Tuesday, because it's so hard to pull those cables. But Todd worked with those folks and was able to allow them to pre-stage those cables so that whenever we had to turn those transformers off so that they could make that reconnect, they did that in around 3 hours. We went cold. We went to emergency generator right at 8 o'clock, and my recollection is that at 11 o'clock we had power, and you saw the pics.
Yeah, it's amazing.
It was amazing the work they did. So the contractors did spectacular work. They worked efficiently and effectively, but it was all staged in a way that allowed them to be able to do that quickly, and that was done because we had people who are experts who knew how to do that in a way that minimize the impact on our facility.
And the neat thing is Todd was there, and he knows exactly how those things were done. You know, and that's so important, because if you know somebody that's there that knows exactly where everything is, boy, that makes it a lot easier if something goes wrong.
Much simpler.
Instead of trying to figure it out. So, tip of our cap to Todd and his staff,
and his whole team,
and to the electrical company for getting that done, and Intercounty, because it took a team effort to get it done.
You couldn't. If any one of those had been a barrier, the hospital wouldn't be where it is today.
You know, and when we all know that there's little issues, like I think the boom truck trying to fit in there.
Well, it goes back to the design thing we were just talking about.
Right.
We had there was the power pole where they had to disconnect and turn the power off was probably put there 50 years ago, and then 50 years
they built a building around it.
They built buildings. They put buildings all around the power pole, so they almost couldn't get the boom truck to it to be able to power off the building. Now we'll move that power out near the generator, and we'll be able to. So two things will happen. One, we'll take that pole down, and in the future, when we need to service and work around that, we'll be able to have access to it.
Planning.
It's amazing. It's amazing.
But it is amazing how when people go and build some new stuff, they don't take into consideration what happens when I have to replace that. They just don't think about it. They just don't. That's not good. Let's get back to the financials. But I want to thank Todd Workman and his staff. They do a tremendous job at the hospital, and really, without them, and of course the great people who did this job getting it done, it would not have gotten. Yeah. Well, I'm not saying it wouldn't have gotten done, but it may have gotten done in more of an emergency.
It would have been much more painful,
and it would have been much more painful.
Much more painful.
All right, let's talk a little bit about financials. We had a profit for the month, or actually revenues over expenses, because the hospital is not for profit. So it is excess of revenues over expenses in this month, and that's always a good thing. About 109,000.
Yep, came in right at 110, and if you look at where we were budgeted to be, because we were budgeted to be have a loss of $90,000, so it's about a $200,000 swing. Now I expect over the next few months that will wax and wane as we go back and forth. But the good thing that we're doing is that, as you just switched pages there, we're preserving cash.
Yep.
We're keeping our cash up. So that's important, is that we're being able to maintain the health of the financial health of the organization, depending on whether it's a payroll day. And when you're non-for-profit hospital, you don't usually have a huge amount of overhead in your profit and loss statement. So
it's very good. And I look at the expenses. The expenses all look pretty much in line. The FRA tag, you never know what that's going to be. Every month that changes, and that's usually the one that really bounced out at me the most, but I think everything else was pretty much in line. So,
and I will say that this is the first
great.
month in a while, according to Joanne, this is the first month in a while that our expenses were below budget. So, we're maintaining expenses, and the team's doing a good job. We're trying to match our expenses to our revenue, and that's how you manage a hospital.
Exactly. And plus, she had to work with BKD in an audit.
Yep, she was in the midst of doing an audit.
Nothing like having fun times at the hospital.
And the good news is that when that's done, it'll be something else fun.
Well, and the neat thing is the comments she made, and BKD is very happy with the way the hospital is being run right now, because they didn't have to spend days. 10 hours?
Yep.
10 hours?
Yep.
10 hours for an auditor to come in and look at the books and check things out. That's fantastic.
And some of the things that we're doing today won't be realized for a year from now.
No.
So we're building a foundation of good financial practices and good financial stability that we will start to see later on into the year. So some of the stuff that we will see where we are having some instability or anything that looks like that in the finances today is things that are getting corrected, but they're getting corrected in the future.
And being a critical access hospital, we always know there's going to be adjustments made for Medicare and Medicaid.
Yep.
And that's why BKD comes in and they verify those numbers so that those adjustments can be made, and then you get reimbursed, or sometimes the hospital has to pay if they make too much money.
And the other thing that we're doing is that we're using the CPSI data better, I think, to better forecast what those contractuals are going to be. So I think we're probably a little closer to accurate on forecasting our financial our contractuals, and maybe we have been in the past. I think we've probably been doing it sort of based on intuition, and I think we're doing it on a little more sophisticated modeling now.
And that's big, because you put that money aside. That money is cash flow, and when you put that money aside, and if it's not needed to be put aside, it can really put a damper on the hospital when they need that cash.
Yeah, and that's like what I was telling the team this morning in our first huddle. That's what we watch, when we watch it every day.
And you have to.
Every day.
You have to anymore. 50 days cash on hand. You like it a little bit higher, but right now we're still in good shape with $3.8 million in the bank, and we're moving forward.
It's better than it was.
Oh, you betcha. A lot better than it was.
A lot better than it was.
And one of the things, if you don't mind taking a minute or two, well, we did talk a little bit about, especially when they looked at the money last year, of course, when we had, people say, well, at one time you had 150 days cash on hand. Well, yeah, you did, because the government gave you just this influx of money.
Around $10 million.
Right. And so I think with all said, it was closer to 12, I think.
Yeah, it could have,
they got. But the thing is, when you get that $12 million, in the case, and this is brought up at the meeting, and I'm glad it was brought up, that many institutions like education, many businesses, small businesses, did not have to pay that money back. Hospitals did.
And I think a lot of our colleagues in the healthcare industry felt like that they would not have to pay that back. And so they assumed that they would go from a loan to a grant. And when it didn't go from a loan back to a grant, they were scrambling, because not only did they have to pay back, if we hadn't paid back when we did, and we finished paying ours back in September, if we hadn't done that, we would be having enormous interest and penalties that started October 1st. So some of those things that you're seeing in those finances occurred at a time when we were paying significant monies back to Medicare. I think it was $2.2 million this year that we paid back to Medicare. So to be able to recover from where we were, still pay those debts off, be at 50 days, and have $3 million cash,
pretty good,
is
fantastic.
Tremendous. It's tremendous.
And your reimbursements, and we all know Critical Access Hospital reimbursed by Medicare. And when they got that loan, they weren't even reimbursing you, not the 99%. It was 75%. Then it went to 50. It would have gone to 25, and then they weren't, until they got their money back, you weren't going to get anything.
That's correct. That's
you
correct.
know, but the hospital had the foresight to get that done ahead of time. You got as low as the 50% level. That's it, right? And then the hospital had it all paid back. That's fantastic. And you're paying it back, like you mentioned, get that money in with 50% of the money you're getting. That's not going to cover your expenses.
No, it doesn't. Well, you know, and that's one of the things I was when I was at my when I was at the auction of the house that I bought. I was talking to somebody, and they were saying, you know, I just don't understand. We pay all this money, and it costs all this amount to be able to have health care, and I don't understand how you all, you know, so many of them are going out of business because it's unbelievably expensive to be able to run that, and most of the payers that we deal with do not cover the cost of the care we deliver for the patients. True. Most of them don't, and so and again, I'm going to pull this number out of the air, but I would just suspect that about 60 or 70% of the patients that we see, the payers do not cover the direct cost, and that's one of the things that helps by having the critical access hospital. And one of the things that, frankly, we're gonna do better than I think we've done in the past, which is reserve those costs and bad debt in a way that we can take credit for it for the care that we were given that we weren't compensated for.
There you go.
If we do that, then we'll pick up additional payments from the government. We will not get that full payment this year because we weren't recording it in a way that allows for it. That's one of those things that I was saying that we won't get until next year.
Right.
So the good behaviors and the good practices that we're doing today are good because those will allow us to be more successful next year. And so, you know, that's the way this works.
You got to have the data. They won't pay to you.
They won't pay because we weren't doing it right.
Yeah, very good. Ashley Sullins gave the chief nursing report. Still needs some nurses, so if you're interested in being a nurse at the hospital,
we'd love to have you.
Please call them. If you are an RN, they'd love to talk to you if you're looking for a job, or if you'd like to become an RN.
If you're in any part of healthcare, give us a call.
Yeah, they would love to hear from you. The nice number she gave for COVID-19, 7 cases in Dent County.
Yep.
So we're in the green category, which means we're in good shape. And also said that the hospital employees can get their flu shots now. Flu shots are available for them.
Flu shots.
Very good. Human resources update, she gave that. Pretty much an even month for the hospital employees leaving and coming.
Yes, I think so. We've had a good, you know, and that again, that's one of those things that will wax and wane because the things come in groups and leave in groups, and so I suspect that we won't be quite as good in October as we were in September, but over the course of the year it balances out, and I will say that that we're pretty stable. Right. And one of the things that we're doing is we're looking for creative ways to make sure that we can get some long-term, you know, folks into the lab, and that was talked about. And unfortunately, one of our key resources is in Florida, and they're going through a little bit of a pickle right now.
I could imagine. Yeah. Okay. Very good. All right. The Hospital Foundation has scheduled a cornhole tournament for next year.
In the spring of next year, and I'm looking forward to that. That sounds fun to me.
It'll be fun. And they're going to revise the Dancing with the Salem Stars.
Dancing with the Salem Stars.
It's been dead since COVID, unfortunately. They had to kill it. But in February 17th of 2024. So
we just put it into a little coma. We're going to revive it.
You bet. And the Community Foundation of the Ozarks is meeting with the Hospital Foundation. That's at their next meeting, right? Or did they?
They are going
to
in December. They'll be doing
very good. That will be December 7th. But so put that down. I know you may not have a calendar. It goes to 2024. So put it on a sticky note, stick it on the refrigerator, and start practicing now.
That's right.
Dance with the Salem Stars.
And I will watch you.
Well, the way my knees are, I'll watch you too. No doubt about that. Moving into a little bit of old business. We kind of already talked a little bit about the transformer and all the great work done there. Let's talk a little bit about that kitchen drain. We know we've got a little issue with the kitchen drain. It's not that it's a new drain. It might be a new drain, but it's an old building.
So that's what. So actually, it's an old drain in an old building, and it's one of those other things that just suddenly popped up 20 years ago. That we're working through. So we're working through with the architect to figure out how to fix that drain. It looks like the pipes are essentially gone underneath the foundation of that building. So we're trying to figure out, what's the best way to mitigate that issue, and doing it in a way that is financially responsible and causes the least disruption to the building and allows us to continue to service our patients. And we'll hopefully get that. We just had that conversation with the architects, a week or so ago, and they're, they're working through that plan.
Take a drink. I don't know if you know, or if they talked to you about it. Was that an old clay pipe, or was that actually an old metal pipe?
I think they were cast.
Okay.
I think they were cast.
That always amazed me, because our family had a restaurant in St. Louis, and they put metal drains in a bar.
Yeah.
And I think you cannot be that stupid.
Well, but you know what? You know what, though? When people did it, that was the state of technology, and they weren't doing it with the expectation that that same pipe would be there 150 years from now.
Well, no, but, the carbonation.
It's not good for that.
It eats it up 3 times faster than just water. And so, that was the thing.
Just think of what it's doing to you.
Yeah, exactly. But they already knew that when they put it in, and that's...
So I suspect if we had done clay pipes, those clay pipes, there's clay pipes in Europe that have been there for 1,000 years, and they're still there.
Yeah, especially in those larger clay pipes that are linked together. As long as you don't have an earthquake or something, you're in pretty good shape.
Pretty good shape.
Anyway, but very good. So that is being looked at, still being diagnosed. But you said they'd put the grease trap outside, run the excess off the grease trap after it clears out the grease down the lagoon.
Yep.
Yeah, that makes sense.
Yep. So again, we'll have to see what the plan is and how we stage it and how we make that happen.
And then work in the dialysis unit.
What's that?
Work in the dialysis unit?
Yeah. So we have got one more. They did. So there are 2 things that's going to impact the dialysis unit. We got one more. We've got one more switch to one more mini transformer to put in place for the transformer project that'll happen in November. We'll have power off to the dialysis building. But then when we had our survey from the state, they noticed, and it's interesting, they've been probably surveying that building forever, and they noted that they didn't like the way that we were doing some of the things in there. And again, Todd and his crew went in and completely renovated the area where we sterilize our water and do our water treatment for our dialysis patients, and it looks night and day different.
It's amazing.
It's amazing different.
Amazing what they can do in a very short period of time, isn't it?
Yeah, and that's why I take pictures of those things. I want pictures of everything so that we can show the befores and afters. Because if you just come in and see it after, you go, well, I
don't see anything different.
Yeah. But so it's very good to document those things.
You mentioned when we came on the air, actually, about the phone system, and there's a new phone system that the hospital has looked into and has approved.
Yeah, we got approval on the board to do a new phone system, and I will tell you that we were a little concerned because it looks very cheap, and sometimes things that look too good to be true are not. But Jeremy did a lot of due diligence. He reached out to talk to the phone company. He reached out and talked to people who have used it, and it looks like it'll be a good solution for us. And again, that's one of those 20-year-old problems that suddenly popped up, and I think we've been talking about it for a long time, and with this approval, we should have that project kick off in a couple of weeks, and it'll probably take about 90 days because there's some infrastructure that we have to put in place to be able to do it. But then when we do that, we'll have a new system that should be more stable.
I'm showing my age because I remember when they got the last phone system, when they bid that out.
Yeah. It was not this price.
Oh, no.
It was not that price. No. So one of the things that technology has done, sometimes it's making things more expensive, but some things are much, much cheaper because you wouldn't have been able to do one room in that hospital for that price.
$5,885 annual cost. That's a great price.
Yeah.
It's going to be a great price. And so the board did approve the Avaya phone, and that's going to be through 3CX out of Springfield, Missouri. Yep. Very good. So as we talked about Allscripts and over at the clinic, we're on Allscripts. Now we're at CPSI.
That's correct.
And so we have a lot of records in Allscripts.
That's correct.
A lot of records. Like 16,606.
That's last count. That was the last count, and that's what we believe at the moment. But what we have to do is we have to get those in, and so all of those, obviously they were in CPS. I mean, in all scripts, and they were electronic. Unfortunately, the format for the old system doesn't match the new system. So we're contracting. We got a couple of bids to contract people who essentially write software to convert the old records from that standard to a new standard, so that we can import them easily from all scripts into CPSI, so that the record stays current.
Of course, that's not free, but you got it at a pretty good price. It's $16,606.
$1 a record is
that's pretty amazing.
Pretty cheap.
Pretty amazing, and that was approved by the board as well. And then you talked with the board about one of those 50-year-old issues.
Yep, we had a pressure regulator valve that suddenly Todd could stand it in my doorway on a Friday afternoon and said, "Boss, we got another issue," and it was.
Did they see that while they were in the building, or was it something that they?
So what happened was we suddenly started having like phantom pipes just shaking, and they couldn't figure out what the heck was causing the pipes to shake, and so we were having just jarring on the pipes. And what they discovered was that our pressure regulator that takes the incoming water pressure and reduces it down to 60 pounds was not stable anymore and was suddenly failing, and so you were having big pressure changes in that pressure regulator, so it was no longer regulating. And so what happened was there was one 3-inch pipe, and again back to pipes next to electricity. So right in that same room we had a little leak in our 3-inch pipe that we repaired, but we lost some insulation off the pipes because it was shaking that bad. So we've ordered another pressure regulator, and so it looks like next week, and I'm thinking that next Thursday we'll take the water down for that building, and we'll replace that incoming pressure regulator.
You're lucky you didn't have a lot of other water issues
God bless
somewhere
us.
Because of that increase in pressure
or
decrease in pressure.
Well, so one of the things that always that frightens me is that if you have 50-year-old piping and it's shaking 50-year-old piping, sometimes those joints are brittle, and it could have been far worse. So that's why we went very quickly. Again, I've only been here 6 weeks, and I think that was a week ago I heard that. So we've already ordered that part, and it's coming in. It's coming in soon.
$4,931, but once it's replaced for another 50 years.
We hope.
Yeah, there you go.
Or sell it when we sell the building.
There you go. Marketing and community relations. Okay, so Tiffin Felgerson, the community champion, has gone through her training with Delta Regional, right?
That's correct.
And so we're going to have a community event by invitation only come November 10th at 9 o'clock until I think it's 11. I think it's or near noon. That's going to be at the community center at the Armory.
Yep.
And that's going to be a real good powwow, isn't it?
Yep. So one of the things that I've done in every market that I've been in is I want to reach out to the community and the people who are users of our health care and who are thought leaders in the community to let's look at what the future needs of the facility are. What are some of the services we do that you're very proud of? What are the services where we may be lacking? What are some of the things that we could improve on? And because we're healthcare providers, and sometimes we like cool toys and we like new things, but that may not be what the direct need of the end user are. So I always want to reach out to the end user and find out what we're doing well and what we could do better. And
get a view from the outside.
That's correct.
That's what you really have to see. You can look at it from the inside all the time, but you're not going to see what people see out there.
Other people see. And then we'll take that information that we'll get from there, and we'll compile it, and we'll take it, and we're having there's also on one of the timelines for future events we're having in December, we're having a retreat with the board to talk about strategic planning and what do we want to do. And we've talked about a few times here that we've come through a little bit of a tough spot. Well, it's time. The good news is that that we're financially more stable, and we're not taking our hands off that tiller. We're not stopping thinking about that.
Yeah.
But we have to stop focusing on that. And now that we've got that behind us, we need to start focusing on the future and what we're doing ahead of us.
And making sure the services that are available, that people know about, that people utilize those services to the max, because that's how you're going to maximize the use of your hospital.
That's correct. And what are the things that people trust us with, and what are the people less likely to trust us with, and how do we improve that trust level?
Okay. And you've been out and about in the community. You're at Old Miners Day down in
Yep.
Viburnum. You were
Yep.
also at the Health Expo out at
Yep.
Salem Community Center at the Armory. And you also were down at Bunker on the 15th in the Bunker Fest. They had
Yep.
their Oktoberfest down
Yep.
there.
And and I will say that the hospital does a good job of being visible in the community and reaching out. So it's good to have that connectivity.
Very good. Okay, so you're gonna the MHA convention comes up in the first week of November. I think it always comes up first
Yep.
week of November, and this will be your first one.
It'll be my first one in
very
in
good.
Missouri. I've been to ones in Tennessee and Kentucky,
Very
and we didn't have them. We had ours remotely when I was in West Virginia because we were enjoying the pandemic, and so we didn't get to do that in person.
Okay.
But we'll do this in person, and I think those are always good learning events. But as I said to the board, I think one of the most valuable things is getting to meet your colleagues and talking with them about what their struggles are, and figuring out how they've worked through those, so that you can learn from each other, because we're all in this together, and we want to compete, and we always want to be the best, and we want to be the best provider. But everybody that takes care of patients are in this together. We have one
Sure.
mission, and that's to take care of humans.
Sure, and it's a good way to communicate and touch base with other people who are in the same boat you are.
Exactly.
And then find out maybe they have a good idea that brought them out of that
Yeah,
problem. So,
everybody has a different perspective, and everybody brings different resources. And the more we can bring different resources to the table, better we are.
good suggestions are never a bad thing.
Yep.
Good. Next board meeting will be November 22nd. There'll also be a finance committee meeting that afternoon. That's the Tuesday before Thanksgiving. Our next get-together will be the following Tuesday. You are aware of that, right?
I am now.
Okay, because I didn't think you'd want to come in Thanksgiving morning.
No, I like you a lot.
Not that much, though.
Not that much.
Not that much. All right, very good. And as he mentioned, strategic planning December 8th. The next board meeting in December, though, will be earlier because of the holiday.
That's correct.
And they'll have it on December 14th. And it's usually a medical staff and board meeting
We're
get-together.
combining that.
Yeah, very good. And you went into closed session. Anything exciting? Any votes taken?
Yep, so one of the things that we talked about is we're going to be working through our masking policy, and there's some regulatory issues that we have to batten down around that, but we will probably have a different masking protocol soon.
Okay.
And then
Well, when that comes out, we'll work on that.
we'll know what that
Yeah.
that'll be communicated to
Yeah,
everybody.
sure. Absolutely. Very good.
And then and we've got new and fun and exciting things coming up. I'm encouraged. I will tell you that I've been here. This is my 7th week. It feels like my 7th month. I feel very comfortable here. I'm enjoying what we're doing. We've got good people who do good things, and we just need to give them the tools and the policies and procedures so they can continue to do a great job.
And I want to compliment the board because obviously you're there, but you have the surrounding staff that can answer the questions. And the board has been asking a lot of questions, and I think that's great.
It is.
Because a board that's silent and just sits there and takes it in, you have no feedback as if they know what's going on or not. And I just wanted to compliment the board because it
I
seems
agree.
like they're right on top of it, and they're really asking a lot of good questions.
Yeah, I
too.
want active, and I enjoy an active, engaged board, and we have an active and engaged board. That's helpful to me.
So I really enjoy going to the hospital board meetings because I like to hear the questions that they're asking.
Yep.
It really does open up a lot of doors for
Well,
mind to start thinking. Well, if they're thinking that way, I understand that. I can get a little better.
It's sort of back to what we were talking about, going to the MHA, where you meet other people, you get outside information. One of the things that's hard is whenever you're in the midst of in the midst of the swirl, and there's a lot going on in healthcare right now. It is really easy to get closeted and introspective and focused inward, and you have to really work hard to stay focused outward. It's so difficult right now, and that's one of the reasons that we're putting together this meeting that we're having with the community. That's why we're doing our strategic planning retreat. That's the reason that I try to be as transparent as possible with what we're doing, so that we can get feedback from people. If you don't make the effort to do that, you will be insular, and you won't be as good as you should be.
Well, you've been very forthright in letting people know just what's going on, and I really appreciate that, because why tell them something that's vague? Just tell them this is the way it is, and we're working on it, and this is what we're trying to do.
I had a good leader once tell me it never gets worse than the truth. The truth is always the best
you're
answer.
right.
It never gets worse than the truth.
Very good. Well, we really appreciate you.
Thank you.
Wayne Reid from our Salem Memorial District Hospital, the CEO, and we do appreciate him taking the time to come in and talk with us. And we do want to tell you that Imminent Insurance brings you this interview. We thank Keith and the entire staff over there for allowing us to take this time and talk with our friends from the Salem Hospital. They also bring you those interviews that we have on Wednesdays, and do want to thank them again for all the work that they do. And if you need insurance, talk to them in insurance, whether it's Medicare insurance, which I'm getting ready to get on, or any other type of insurance, home, health, life, business. They can take care of it for you. Workman's comp, that's all coming up stuff too. A lot of stuff goes on. We really do appreciate him in insurance bringing you this interview with Mr. Reid and all of our friends at Salem Memorial District Hospital. Sir, thank you again for coming and spending some time with us.
Thank you, sir.
Appreciate